Hello everyone, this is Dr. Sanyukta Shrivastava. The topic of today's video is injection trismus. So what is an injection trismus? It is basically a reduction in mouth opening and pain after you have one of those inferior alveolar nerve blocks. Now let me mention it today, this video is for my dentist friends, so I'll be using a number of technical terms and it can even be understood by the general population for you patients. I will try to make it as simple as possible. So let's get started. Whenever we as dentists give any inferior alveolar nerve block to any patient, we might injure the medial pterygoid muscles. So once we get into those medial pterygoids and injure them a little, the body may start giving us an inflammatory reaction there. There is a release of substance P and bradykinin, which causes local changes in the muscle tissue. This is called as local muscle soreness. It is a masticatory muscle disorder, which we all know as injection trismus. So when these muscle tissue changes are set up once we give an inferior alveolar nerve block, there is localized inflammation that causes pain to the patient. Now this pain goes to the central nervous system. Our body is designed in such a way that the brain is trained to protect the entire body. So once there is any injury or there is any threat of injury, the brain tries to send impulses to the peripheral structures, the masticatory muscles in this condition, to reduce the range of motion, reduce the force of motion, reduce the degree of motion. So it starts producing simultaneous contractions into antagonistic muscles, which simply means that when you injure a muscle, the brain stops the activity of the acting muscles and asks the opposing muscles to act along with them to prevent any further injury to those structures. So when the patient is trying to open his mouth, the elevators come into function and they try to close the mouth. When they try to close the mouth, the depressors come into action and they try to open the mouth. So that is why there is a reduction in range of motion and the degree of motion in a patient after there is an injury to the medial pterygoid muscles after your inferior alveolar nerve block. Now there is a very interesting fact about this whole mechanism. This is designed to protect your system. But if you try to oppose it, if you try to open the mouth opening forcefully, if you try to oppose the protective co-contraction that is designed to protect your masticatory muscles, then it produces more pain. And this pain in turn will again elicit the brain to produce more co-contraction. Now, one very interesting thing about local muscle soreness is that once it produces protective co-contraction, and if the cause is not removed, or if you try to oppose the protective co-contraction and do not allow complete healing, then this protective co-contraction in turn leads to local muscle soreness. So when you give an inferior alveolar nerve block and the tissue got injured, the patient had pain, the pain started the co-contraction, there was limitation in mouth opening, but you forcefully increase the mouth opening, you ask the patient to undergo physiotherapy, you try to open the patient's mouth forcefully, or they try to open their mouth forcefully, there would be more pain and more CNS stimulus and more co-contraction, and the cycle will continue for months together. I hope you've understood here that the culprit is not the reduction in mouth opening. It is part of the solution, not part of the problem. The real culprit is the pain. So what you really need to do is stop the pain cycle somewhere. Now, here I would want you to think, since you have understood all the pathology and all the physiologic actions that our body is taking to protect our body and how this all is coming into play, do you think physiotherapy, opening mouth forcefully, or asking the patient to exercise, or you yourself putting instruments to open the patient's mouth forcefully is all that going to work, or is that going to worsen the problem? Second thing, do you think that muscle relaxants will be of any help to you? Muscle relaxants work in muscle spasms. Is this a muscle spasm at all? So of course the muscle relaxants will not have any role to play here. One more important point that I would like to mention is that muscle relaxants actually do not produce any muscle relaxation of the masticatory muscles at their oral doses. So actually whatever effect of pain relief we feel with those muscle relaxants is attained by the sedation that the patient has. So they really don't have any role to play in all these disorders. Now what do we do next? Once we have understood the whole problem, we have also understood that the real problem is pain. So you need to stop the pain cycle. Instead of asking the patient to open mouth forcefully, you're supposed to ask the patient to restrict mouth opening within painless range. You have to ask the patient to take soft diet, bite slowly, have smaller bites, and keep the lips together and teeth apart. You have to make them aware that they are not supposed to let their teeth meet during the daytime when they're not eating. One more thing that you have to ask the patient is to take an anti-inflammatory in time-bound manner. By time-bound manner, I mean it has to be regular doses for a fixed period of days. It is not supposed to be SOS basis. So every 4 to 6 hours, the patient is supposed to take an anti-inflammatory for minimum 5 to 7 days. Now, one more proposed treatment is hot fermentation or cold fermentation or laser photobiomodulation. So all these three mechanisms, if they're available with you, the laser, you can do them. They are supportive. The patient may do hot fermentation or cold fermentation on as and when needed basis, or whenever if they feel comfortable with it. But there's no major treatment role in this disorder. If the patient is a parafunctioning patient, if they're clenchers or bruxers, or if they report that the pain and reduction in mouth opening is the most in the morning, especially the pain part, you can make a stabilization or a permissive appliance for these patients, but most of the times it will not be needed. You have to understand that it was a small tissue damage which started the pain, and the pain started the contraction, and that is why the mouth opening is limited, and you need to let the pain subside for the disorder to disappear. Once the pain is gone, the mouth opening will improve on its own. It will take 1 to 3 weeks for the patient to be absolutely normal. After 1 to 3 weeks, when the pain is absolutely zero, if you still feel that the mouth opening has not returned to the normal, you can institute passive stretching exercises, passive mouth opening exercises, and that's it. I hope you liked the video, and I hope I could demystify the injection trismus. It has been a very commonly discussed and a very commonly misunderstood topic. I hope I made a little contribution to your knowledge. To know more about these disorders, please stay connected with my Facebook page, that is Demystifying Dentistry. That is supposed to be for all my dentist friends, and for the general populations or for the patients to come into contact with me. The link and the address is in the description box. Here I am thanking you to watch my video.